show up or be challenged in ways in another environment. And that's why this basic information is so important, because the issue in this case, drug abuse and addiction, will show up in different ways in different settings, and it's important to have that basic um, information. Then I will do a slightly deeper dive into marijuana, because its use is increasing, in part because it's being legalized across the world. That's being associated with an increase in its use, and therefore its human effects, its physiological effects will show up in people, and it will show up in your patients. And so having an understanding of what happens when people abuse drugs or are using them supposedly for therapeutic reasons, the basic physiology of these substances are important to understand. And then lastly, I was just going to end with um, a note about overall public health issues in an attempt to get you to take in this overview, but to have it incorporated into how you think as a physician when you're taking care of your patients, when you're sharing information with your colleagues, when you're teaching your students and your colleagues. So with the next slide, I just want to introduce um, the official list, or the official schema of the so-called drugs of abuse. Um, this schema is, it says here, it's the United States drug schedule chart, but it's actually an international chart. This chart is the result of an international treaty. Believe it or not, the world got together through the United Nations to come up with a schedule, or a way to think about, rank, categorize different drugs of abuse based on, at the time, this was a while ago, um, uh, levels of danger, levels of addiction um, that are reflected by each of the schedules, with Schedule 1 being the most intensely and quote unquote dangerous in terms of dependence on a drug, the addiction rate, and then getting lighter as you move down the scale, to the point that Schedule 6 here is listed as over-the-counter medication, and that would include substances such as caffeine. I had my share of caffeine this morning when I woke up, but it is a substance that, if you take too much of it, can create a problem. Some of us are more sensitive to it than others. I'm not going to spend a lot of time on these various substances, but only want to introduce the idea that there is a system, an organized way of thinking about these substances, and where a substance is located in this schedule is not supposed to be determined by politics. It's supposed to be determined by research, and then discussion among clinicians about where these things should live. And that's in a perfect world. And that would be another a discussion about the ins and outs of what I just said. So with the next slide, I want to introduce the idea that drug abuse and addiction are two very important behavioral phenomena. Um, they drug abuse is it's a choice. A person makes a choice to use a substance for its effects. Most people are looking for a high. They're looking to feel better when they take a substance into their body. There are various routes of administration. Addiction is a separate phenomenon, and I'm going to walk you through, if you're not aware already, of the research that helps us to distinguish both of these. But addiction is um, a, a chronic, obsessive use of a substance, even in the face of negative consequences. A person is not able to control their urge or their seeking behavior of the substance because they have become attached to the substance to the point that their new normal level of behavior and feeling is determined by their ability to keep certain receptors filled so that they can attempt to live a quote unquote new normal life. But drug abuse and addiction are not issues that are solely determined by an individual's ability or an individual set of values. The stigma associated with drug abuse and addiction, the fact that most people are looked down upon in a way that they should be able to control their behavior. The research makes it so clear that there is a biological basis. There are genetic predispositions. There are an array of them. And any one of us could become addicted to a substance or to other behaviors, anything that would turn on the brain mechanism or stimulate the brain pathways that would result in the feeling of pleasure. And so if you could appreciate that this is a complicated issue where the brain is the central character in this play, if you will. The brain is our it's a liminal figure. It manages an individual's ability to negotiate what is going on in our environment, in one's environment, outside, and what is going on with our environment inside. That's what our brains do. Now, our personalities and other psychological issues live there too, but how we go about negotiating the environment and ourselves is what makes us unique. But that is the organ, just as arteries are the important organ in PAD, the brain is the important organ in drug abuse and addiction. So with the next slide, I want to talk just a bit and to give an example about the epidemiology of drug use. Drug use is increasing in the world, not just because marijuana use is increasing across the world as it's being legalized, but substances are being used by many groups, different substances in different parts of the world. But I do want to take a second to point out drug use in the United States up until about 10 or 15 years ago, when legalization of marijuana started to take place. If you looked at actual drug use rates by the entire population in the U.S., what you would see is a huge peak of use before age 20 in this country, and then a heavy drop off of substances of abuse. What's not in the on the graph is an increase. You see an increase in alcohol use and an increase in tobacco use, and then that has changed over time. Those are legal substances, but if you looked and mapped out the epidemiology of illicit substance use, basically driven by marijuana up until a few years ago, and that's still true. This peak indicates that the heavy drug use was actually a pediatric issue. This was pointed out by the head of the National Institute on Drug Abuse at the time, that she took over in the year 2000, I believe. And it illustrates a very important way about how we think about and digest and use data. I could go through and give a technical description of this information, epidemiologic information about drug use. But to look at it in a way that a clinician might look at it, in a way that a community member might look at it, in a way that a young person would look at it, that is very, very important. And the point here that I want to leave is that you as clinicians, as you're taking in data, it's very important for you to use it, to mold it, so that it helps you as you go about being an excellent practitioner, and as you go about improving your skills. That perspective is really important, how you think about and how you use the data. Let me move on to the next slide. So earlier I mentioned that the main reason why people use drugs is because they like the way it makes them feel. And there is a biology to this. I will mention that for the young people, the other motivator is curiosity. They either want to make themselves feel better because they're not feeling that great, or they're curious about how these drugs will affect them. And what we've learned in research in mice, and now we've been able to look at, and I'll show you in a second, technology that allows us to look at brain function in real time. We now are aware, and most of you are aware of, the dopamine basis for pleasure. And it turns out that drugs of abuse are able to go into the pleasure center and release dopamine. In rats, we've been able to show that when you have a really good meal, like the one that I had last night with my mother, I got a dopamine spike because I experienced the wonderfulness of the seafood that we had. Sexual activity is something that human beings find very pleasurable. And you get basically almost a doubling of the dopamine release during that wonderful activity. You multiply that intense release of dopamine by 10 or 20 times, and you get the high that is experienced when people take various drugs. Most of the drugs create this scenario. And without going into further detail, this is what's happening. The research is able to show this over and over again. And we can talk about getting high as a stimulation of our reward system. In the next slide, I want to show that over time, when this system is constantly being stimulated over and over and over again, the dopamine levels end up getting depleted. And so what you see in this series of PET scans on the left are normal, supposedly normal human beings with healthy, ripe pleasure centers. And then what you see in the column to the right are folks that have been on heroin for a certain period of time, who've been on alcohol for a certain period of time, meth and cocaine. And you see this blunted ability to experience pleasure. Clinically, we see that in people who have become addicted. They don't enjoy things as much. And this research and biology is able to demonstrate that. So with the next slide, we can see that not only in the base and most primitive part of the brain where pleasure lives, but in the outer part of the brain as well, it gets depressed in people who are abusing drugs and become addicted. And it helps to explain why so many of these folks respond positively to antidepressants when they're right after they're detoxed and engaged in treatment. And we see a similar picture as shown here, that the cortex in depressed people is depressed in terms of brain activity. And we see the same phenomenon in folks who are addicted. With the next slide, I want to show that both in the outer, most developed part of the brain and in the most primitive part of the brain, research has been able to show that specific circuits get emphasized and others get de-emphasized. Some are more important in terms of getting high. And then over time, those circuits sort of morph or change to support and reflect the repetitive behavior of going after drugs to maintain the addiction. And again, research has been able on mice and on human beings to show where these changes are actually taking place, what neurotransmitter systems are involved. And by looking at this basic data, it gives us some idea of where to intervene therapeutically, what biological interventions could be developed to change these circuits back or interrupt some of the circuits so that to help the behavior change. Now, having said all that, these circuits are already in place. We're already using them. And I have used this slide in the past to show that, yes, I'm showing you a picture of biology, a picture of the biology of a working brain. But it's also a picture of what is happening or what is going on psychologically as well, and also what is happening socially. Because this same brain with these same circuits are interacting in the environment. So if I was able to find a substance that could affect glutamate in a way that would help this person with this brain make better decisions, that same effect on glutamate may be trained, or it may be something that could be the result of experiences in a psychological therapy, in a therapy with a social worker or psychologist or psychiatrist, or in a group setting, or you move somebody out of the environment where drugs are available and there are places where the person can go and use them, and you move the person to a new environment, that has the same effect as a drug might on these same circuits in the brain. And I'll cap that point in a second after the next slide. So to put a name, a clinical name to some of these tracts, some of these circuits, the brain is able to squelch impulses. We're all motivated to do things. We all seek rewards. That's what allows us to live our lives, to move forward. And we need memory and learning to remember how to go back and get that reward. What motivational attempts to do something ended up successful and which ones didn't. And you can see that all of these exist in a balanced way in the brain. When you're molding a child, you're teaching someone to be a better physician. All of these things are working together in the brain, and you can appreciate that the scales get tipped, an imbalance gets created, as shown in the next slide. An imbalance is created, and that is our picture, or that is how research is trying to help illustrate what happens with addiction. And I'll just point out, and again, I want to draw specific attention to Dr. Nora Volkow, who is still the director of the National Institute on Drug Abuse, just prior to her coming to the National Institute on Drug Abuse to run it, had been doing had been demonstrating this work by generating some of the very, very first brain scans showing where drugs of abuse go in the brain and their overall effect. And that's why how she was able to come up with this schema to show that when frontal lobe control and more basic drives and motivations, how they're related. Memory is used to remember how you were successful and not. And this whole issue of saliency, we think we know where that lives in the brain now because of studies on drug abuse and addiction. What is important? How do we determine what is really salient for us? But over time, as the brain changes, these areas change, their functions change. Notice how the arrows have changed. And I don't want to say the size of these parts of the brain have changed, but the issues and how these areas function in the brain changes over time. And I'm hoping that this pictorial allows you to capture all of the complex concepts that come together to demonstrate and illustrate what a non-addicted brain and an addicted brain is, and what would be needed to reverse, what would be needed to bring things back to normal again. And at this point, let me just say that in general, drugs of abuse, with very, very few exceptions, do not kill brain cells. They're changed. The inhalants, alcohol in very, very high concentrations, and methamphetamine in general, those are the only drugs that actually kill brain cells. Methamphetamine causes an apoptosis. It actually tells brain cells to commit suicide, and it's unique among the drugs in that sense. But other drugs of abuse don't damage the brain per se. And that's very, very important because it's an important thing to realize that you've got something to work with and to work for in terms of treatment and intervening to try to bring the brain back. Next couple of slides, I'm going to race through these because I'm over time. Back to some of the epidemiology. Because of the legalization of marijuana, we now see more marijuana use than alcohol. And there are consequences to this that we've got to start to take into account and that we have to discover and characterize. We don't know a lot about, or we don't know the full effects of marijuana on the human body. We do know, for example, that chronic users have issues with their blood vessels such that they are challenged in terms of their blood vessels being able to dilate. This isn't so much a new finding, but it's something that we don't know much about because we haven't done much research on THC, that particular component in marijuana, and cardiovascular issues. Those things are starting to be ramped up in terms of research. NIH has got most of its money back, and hopefully we can get some of those research programs back on track. But I give that as an example, partly because of the audience, you as the audience. But we're in a changing time now where marijuana is much more common than alcohol, and we've got to be doing research. We've got to be taking in that research as we deal with our patients. And I'm going to end there because I've gone over time, and I can take questions or we can have discussions later.
Thank you, Dr. Murray. Thank you so much for the most interesting talk this morning. We're excited that we learned a little bit more about drug addiction. One of the concerns a question I may have for you is what's your experience with the use of drugs such as tramadol in conjunction with marijuana? And do you have much experience with that? Because I see in my travels, there's a high use of that in Nigeria.
I don't have much direct experience, but you are pointing out these patterns that can exist in places, and that you're underscoring the very important need to do the epidemiologic research and to understand how these are being developed. Is this happening in Nigeria because of availability? In the United States, there are often pairings of different drugs based on what was available, sometimes what was being pushed at the time. Um, and so it is important to follow and understand these trends because there are physiologic and other medical issues that may arise that are unique to that particular combination of drug use. So
I
my
get that.
response is it would be very important to follow up on what that is. We have a system in the US. It's not very well developed, but it's locally based to try to detect new trends like this because it says something about not only what's available, but what's the motivation for using those together.
Yes, I can tell you a little bit about that. I think this is usually more common in college students and younger folks.
Hmm.
High doses of tramadol, we're talking about up to 2 grams, apparently makes them supercharged. And
Yep.
then they can stay up and study, do whatever they have to do. And then later on, they quell the effect by taking marijuana to calm
Hmm.
down. Another trend that I've seen in some part of Africa, I believe it's Sierra Leone, is where persons go around, um, they degrade graves and dig up the bones and then sniff the contents and makes them like zombies pretty much. So that's
Oh,
another,
interesting.
yeah.
Hmm.
So that's it's also very common. They just like go to gravesites, take the bones, and I guess once the persons are uh, uh, buried, they use formaldehyde, I guess, part of the
Yep.
deal. So that gives a very unusual high also. So it's an addiction that's common in that part of the world. But overall, we thank you for the excellent presentation. Any other questions from the audience? Dr. Shangade is here.
You Doc.
Hi there.
Good. Good lecture. I wish we can give you 5 hours to, up to 5 hours to talk, but we're limited. What I want the audience to understand is the stigma. You can see the complexity of addiction disease. It's a big subject. And you all have to realize that addiction is a chronic disease, just like diabetes, hypertension. Yeah, I see a lot of my colleagues stigmatizing all these patients. It's so sad. So for these young doctors that are coming up, you should see that addiction can affect anybody, just like Don said, whether you're rich or poor. People that are addicted are not just dumb people or something like that. So that's the main thing I want people to realize. But if Don can comment on psychedelic drug, what do you think where is coming into view now that the president has signed into law that we can do a lot of research on psychedelic? Psychedelic is going to be another big thing. I am one of those pro psychedelic guys. So
Yes.
just
Yeah.
why I have heard
All right.
and
You
you
just
make
want
a
an
quick
excuse
comment.
to
I
try
know
it,
it's taking
right?
a lot of time, but can you make a quick comment on that? Psychedelic. What do you think
It,
is over that?
yeah. Let me begin by saying when I presented the scheduled list of drugs of abuse, the vast majority of those drugs have a therapeutic um, aspect to them. Um, Cocaine is a pretty good anesthetic. Um, you remember that. And so many and that's partly why the the chain by partly why changing um, cannabinoids and in marijuana in general. Well, marijuana will always be Schedule One, but the cannabinoids in marijuana scheduled much lower because they're they're we know that there are some therapeutic, some positive effects from the use of these, and with the psychedelics, we have to study them more. That's we can't shortcut that process. I'm open to the idea of researching them. We have a system in place to be able to do clinical research. We have the best drug development system in the world. And so my reaction to psychedelics is, yeah, they should be ripe to test and for us to do research to understand how they work, when they don't work, what are the side effects and dangers. All of that, we should all be open to. But the fast use of any substance, and the psychedelics as well, without adequate treatment, it's irresponsible. So it is important to do the research, and
Very
we
good.
should do the research.
Thank you, Dr. Perrine. Appreciate your coming on today. We hope you come back and give us another interesting talk some other time in another episode of the Global Grant Rounds. Thank you, and also appreciate the Zuma Foundation as a board member there for allowing you to present this case today. Thank you so much.
Hey. All right. Yes. Thank you so much, Dr. Vereen, for that very insightful and thoughtful presentation. We will now transition into our student case presentations. And I know all our students are very excited to present today. These cases represent a variety of clinical encounters and highlight important diagnostic, procedural, and management considerations across multiple specialties. Our first presenter is Judy Lee.
Good morning, everyone. Once again, I'm Judy Lee. I'm a medical student working under Dr. Oye. So my presentation today will be about retrograde approach angioplasty. So let me go back. So my case is patient is a 53 years old male from Beckley, West Virginia, who presented with severe right lower extremity pain and also the left leg pain. On examination, the patient had weak distal pulses, pallor, and signs of poor perfusion connecting for limb ischemia. Due to the severe arterial occlusive disease, the patient underwent surgical intervention including arteriogram, angioplasty, intravascular lithotripsy, and femoral endarterectomy. Following the procedure, the restoration of the distal blood flow was achieved with strong dorsalis pedis and posterior tibial Doppler signals. So this is the past medical history of my patient. He has hypertension, hyperlipidemia, he has chronic kidney disease, and he's on peritoneal dialysis, and he's a heavy smoker, and he also smokes marijuana. So this is the pre-op CT angioplasty of the patient. So you can see the complete occlusion of right iliac artery. We can also see the occlusion of right superficial femoral artery and the stenosis of the distal external iliac artery and occlusion of left superficial artery and moderate to severe plaque in left popliteal artery. So this is the procedure that we perform on his right lower extremity. This patient underwent a complex hybrid vascular intervention. First, an aortobiliac arteriogram was performed, which demonstrated a severe iliac artery stenosis and poor distal flow. A right femoral popliteal tibial arteriogram was then performed to evaluate runoff and identify the level of occlusion. Because of the chronic total occlusion and severe calcification, a retrograde popliteal approach was used to gain distal access to the vessel. Shockwave intravascular lithotripsy with a 5 by 80 millimeter balloon was then performed to fracture the calcified plaque and improve vessel compliance. Balloon angioplasty was subsequently performed using Dorado balloons to restore the luminal patency of the superficial femoral artery. Due to the persistent plaque burden within the common femoral and the superficial femoral and profunda femoris arteries, femoral endarterectomy was also performed to remove the atherosclerotic plaque and restore blood flow. At the conclusion of the procedure, the Doppler signals and palpable pulses significantly improved. And these are the pictures that we got during the right leg procedure. So these images were obtained during the endovascular portion of the procedure. The initial angiogram demonstrates the complete occlusion of the right superficial femoral artery and popliteal segment. A retrograde popliteal approach was obtained, and the lesion was successfully crossed with a guide wire. Shockwave intravascular lithotripsy and balloon angioplasty on the second, third, fourth, and were then performed across the femoral popliteal segment. And the final angiogram demonstrated the improved vessel patency and the restoration of blood flow to the lower extremity. So this is the plaque that we removed from his right leg. So, I'm sorry. So this is for his left leg procedure that we have done yesterday or 2 days ago. So the patient had an extensive atherosclerotic disease involving the iliac, femoral, and tibial arteries. After initial iliac angioplasty, stenting, and femoral endarterectomy, the patient developed the acute thrombosis of iliac, femoral, and profunda femoris arteries, resulting in acute limb ischemia. So we had to go to the emergency surgical revascularization, therefore performed to restore the blood flow and prevent limb loss. The emergent procedure began with the iliofemoral thrombectomy to remove the thrombus and restore inflow. This was followed by the placement of the dual Gore-Tex bypass graft and a tibio-peroneal trunk to peroneal bypass to re-establish the distal circulation. Additional procedures include endarterectomy of the below knee popliteal and tibial arteries along with the jump graft to optimize the blood flow to the lower leg. At the completion of the procedure, strong distal pulses were restored and hemostasis was achieved, and the goal of successful limb salvage was accomplished. So these are the surgical procedure pictures that we had obtained from his left leg procedure. So as you can see, we can see the common iliac artery, common femoral artery, and its plaque within. So this is the picture of the fluoroscopy during left leg procedure. On the first picture, we can see the 3 stents. We've put 1 stent on the common iliac and 2 other stents on the external iliac artery. And the second picture, it shows the inflation of the balloon of angioplasty. And the last picture shows the restoration of the blood flow. The next picture shows the fluoroscopic angiogram shows the progression of the revascularization during the treatment of acute left lower extremity ischemia. The first image demonstrates the severe arterial occlusion with poor distal flow. After thrombectomy, the second image shows the restoration of flow through the femoral circulation. And the final completion angiogram confirms the successful bypass grafting and the endarterectomy with improved distal runoff and restoration of perfusion of the leg, corresponding with the palpable distal pulses and the end of the procedure. So this is the specimen that we took out from his left leg. For the outcome, so the right lower extremity revascularization was successful with the restoration of blood flow and limb salvage. Also, the left leg revascularization is needed in the future. We did the revascularization and we had a successful restoration of blood flow of the left leg also. So I would like to call the next colleague who is gonna present for the next presentation, Tamara Thickan.
Very good. Before we start, the main concern here is the patient with extensive PAD with occlusion of the iliac artery on the left, which could not be easily entered or improved by doing a femoral exposure because of the plaque burden at the femoral level. So we had to do an exposure at that level and perform an endarterectomy extensively first. Then there was no flow at all. Then we're able now to, by stroke of chance, get the wire to the distal external iliac artery, but could not enter or proceed into the common or the aorta. At that point, you have the option of subjecting this gentleman to a more extensive surgery, such as an aortoiliac femoral bypass, which is a lot more debilitating. So to prevent that, we had to go through the brachial approach. went to his elbow, dug to the brachial artery with an ultrasound, and made a wire go from the brachial artery down the heart level to the distal aorta and to the common femoral, and with then able to capture that wire through the femoral artery exposure on the left. And that was the only way we were able to now effect the balloon angioplasty with the stenting of the common iliac artery and the external iliac artery on the left side to improve the inflow. The concept is inflow, outflow, runoff. At that level, between the aorta and the femoral artery, you're concerned about inflow. You may have wonderful surgery done, but if you don't have blood flow coming from the tank to feed the tap and the house, it's not going to work. So we're able to achieve that. After that, the next critical question is the complete occlusion of CTO of the SFA, superficial artery, all the way down to the popliteal artery, just solid plaque cement. So we're able to open the profunda artery at the same time, and we're going to show that. It's important that when you walk and you have pain, that you understand that it's the SFA that makes you walk. But the profunda blood flow from the profunda or deep femoral arteries will keep your leg alive. So we thought we could get away with just getting profunda open the inflow from the top, which we did successfully, and we had an extensive patch, which is like almost 13 cm patch, to patch that artery that was where the plaque was removed. And we were going to stage this procedure. That's a plaque, you see that. We're going to stage this procedure and bring him back maybe 30 days later and do maybe a FEMPAL bypass. But unfortunately, on the same day, within a couple of hours of surgery, he just got worse. He got a lot more ischemic. And so the stage procedure has been done the same day. So it was brought back, and we then proceeded to do a FEMPAL bypass. And the popliteal artery, the knee level is also involved. So we did endarterectomy to do the bypass, and we were able to be successful in restoring flow. This patient, under normal circumstances, could have lost his limb because the profunda is out. And when we got back, the profunda was all fluid. We can't. We had to embolectomy or thrombectomy to remove the clot to restore the inflow again before we do the bypass. So this is an extensive case. We spent about 6 hours the first time, about another 4 hours the second time to ensure that this fellow did not lose his leg. Again, this is one of the options we see in PAD, and it's a common problem worldwide. It's not unique to Bentley. It's common in Africa. The picture you see today on the screen, I can show you seeing pictures like this in the Niger Delta of Nigeria. So it's a good presentation. Next, please.
Okay. Thank you. I will presenting on FEMPOP bypass grafts. My patient is a 73-year-old female that resides in Berkeley, West Virginia. She actually presented first with left leg ischemia and pain in the limb. Symptoms include pain, weak pulses, and paleness. The plan and management for this patient is endarterectomy and FEMPOP bypass grafts, and the outcome was restoration of blood flow. A past medical history includes type 2 diabetes, hyperlipidemia, COPD because she's also like a current smoker, osteoarthritis also. And a past surgical history includes tubal ligation and cardiac catheterization with PCI. Okay. So the patient sees the angiogram. She actually had a complete left femoral popliteal occlusion. You could actually see from the CT angiogram that the left side is actually occluded, and there's a moderate to severe plaque in the left popliteal area when we're doing this performing the surgery. So the initial plan for the patient initially was left femoral endarterectomy, left common iliac angioplasty, and possible shockwave therapy to the left femoral popliteal. But what was done or performed on this patient was left common femoral artery, SFA, and profunda endarterectomy and left pop bypass with graft. So this was actually done because when we're actually doing the procedure, we kind of like, we couldn't go through with the wire. You could see from the fluoroscopy during the angioplasty that the first image, we tried to like put in the wire to access blood flow and all of that, but we couldn't. So we actually went back and then went through the popliteal area, and this was very calcified. And also the patient artery was also very narrow. So angioplasty and all of that wasn't actually possible. And so we later went through the below the knee popliteal area to access for access. So we actually went through from the. So first of all, we reviewed the anteriogram of the left lower extremity, and then the common femoral artery exposure and endarterectomy was done. And removal of the atherosclerotic plaque from the common femoral, superficial femoral, and the profundal femoral arteries were also done. And also there was exploration of the popliteal artery, but we couldn't go through with that because of the massive calcification there. And we finally did the below the knee popliteal artery. And that was how we kind of like restored blood flow to the patient. And so you could actually see the plaque that was removed from the popliteal area. So the outcome, so the patient after the bypass graft, the outcome was normal left leg bypass graft, which was actually successful, and there was successful revascularization of the left leg, and we actually discovered a strong dorsalis pedis and posterior tibial pulses. Thank you. So,
Nice job. One of the concerns again on a case like this is you have extensive plaque within your artery. We are lucky in the United States that we have the opportunity to affect the restitutional options. In some other parts of the world, they don't. Somebody comes from a challenging problem such as this, the only surgical option they have is an amputation. And again, think about an amputation. Amputation can be very life-altering or life-changing. Depression, which can lead into drug use, excessive pain, and even death. So again, we come up with creative measures or ways to fix problems. Initially, the paradigm shift is initially to do medical therapy. Not every person that has a plaque in the artery needs an operation. We'll always defer the operations to persons that are symptomatic. The reason being, once you affect vascular intervention, the patients can react in multiple ways. The patient can have a blood clot, like the previous results presented. They had extensive problem in the vein and post up within 2 hours the clot. These patients clot because they smoke, they have bad genetics, they have extensive amount of plaque. So again, we have a couple of ways to fix these patients, if not medically, we go endovascular, minimally invasive option. And if that doesn't work to solve the problem, when we say minimally invasive, there are no cuts involved, just wire balloon catheters. We have an array of catheters, wires, and that we could use in stents to improve flow. If that does not work, then we use what we call a hybrid procedure. And this is an example of a hybrid procedure where you try to endovascular, it didn't work now, you have to open, take the plaque out, just open and that then you indeed it. And in this case, I had to do a bypass operation. And then the last option is bypass operation. Bypass operations are foolproof. The reason why we don't like to do bypass operations is for this patient, some patients are not very compliant. They will continue to smoke, increase their risk of thrombosis of the bypass graft. A bypass graft is well done. Somebody who's a non-smoker may last 5 to 7 years at femtop bypass, but for smokers, it could be less, be a year. And you have to go back and redo it, and if it doesn't work, then it will end up with amputation. So we tend to tell them to quit smoking the best they can. And because the risk of a bypass, if they keep smoking, is high, and then they need to let it. So again, we have to prepare them so it doesn't come as a shock when they've exhausted all the possible surgical options and amputation becomes inevitable. Thank you. Next, Daniel.
Hi everyone, this is Kajal Shah. So today I will be presenting. I'm so sorry. So Today I will be presenting a case of 69-year-old man from Beckley, West Virginia, who presented with a threatened limb ischemia, lower extremity pain due to advanced peripheral arterial disease. At presentation, he complained of severe left lower leg pain and a cold foot. On physical examination, distal pulses were absent, raising concern for acute limb ischemia and limb-threatening ischemia. His symptoms were consistent with several of classic signs of acute ischemia included like pain, pallor, absent pulses, and cold feet. Because of the severity of ischemia and concern for limb loss, urgent vascular intervention was required. So as you can see, his past medical history was CAD with prior PCI and bypass, chronic hypoxemic respiratory failure, congestive heart failure, and hypertension. These comorbidities likely contributed to progressive atherosclerotic disease and increase his risk for arterial occlusion. Preoperative CT angiography demonstrated extensive multi-level peripheral arterial occlusive disease of the left lower extremity. There were severe occlusion of femoral popliteal segment with diffuse calcified atherosclerosis. As you can see on the left side, the tibial vessels were also affected, including occlusion of the proximal posterior tibial artery. Distal runoff was poor, meaning there was inadequate blood flow reaching the foot. Overall, these findings were consistent with critical limb ischemia and a threatened limb, placing the patient at significant risk for amputation. Hence, revascularization was not performed. So this was the first procedure we did, was bypass and endarterectomy. Due to extensive disease burden, the patient underwent complex limb salvage surgery. The popliteal artery was first exposed and found to be heavily diseased with significant calcification. A previously placed stent was removed and an endarterectomy was performed. Endarterectomy involves surgically removing atherosclerotic plaque from inside the artery to restore blood flow. A Gore-Tex bypass was then placed to route blood around the occluded arterial segment. Following the reconstruction, an intraoperative arteriogram demonstrated blood flow through the peroneal artery with reconstitution of distal posterior tibial artery. Additional endarterectomy was performed proximally and the bypass graft was successfully connected to restore inflow. At completion of the procedure, Doppler signals confirmed improved distal perfusion. Since, despite the initial reconstruction, residual distal occlusion remained within the posterior tibial artery, so we had to perform the second procedure, was thrombectomy plus angioplasty. A second procedure was therefore performed. The posterior tibial artery was exposed near the ankle and the arteriotomy was created. After crossing the lesion with a guide wire, balloon angioplasty was performed using sequential balloon sizes to dilate the artery and improve the luminal diameter. Completion angiography demonstrated restoration of blood flow through the posterior tibial artery and improved perfusion to the foot. Distal pulse signals were again present, confirming the successful revascularization. So fluoroscopy during the angioplasty. These fluoroscopic images demonstrate the key steps of the angioplasty, the procedure we had done. The images on the left shows diagnostic angiography prior to intervention. Here we can appreciate areas of severe narrowing occlusion with the distal arterial system resulting in a poor blood flow to the foot, as you can see in the second picture. The middle images demonstrate a guide wire. As you can see, the long wire in the fourth images in seen transversing the occluded segment. Crossing the lesion is a critical step because it establishes a pathway for subsequent intervention. After successfully passage of the guide wire, the balloon catheter were advanced over the guide wire and inflated with the diseased vessel. Balloon inflation compresses atherosclerotic plaque against the vessel wall and enlarges the lumen to improve the blood flow. The later fluoroscopic images demonstrate improved vessel patency following angioplasty and restoration of the contrast flow through the treated artery. Overall, these images illustrate successful endovascular revascularization of the posterior tibial artery, helping restore distal perfusion and contributing to the limb salvage. So just to summarize this patient's case, this patient presented with a critical limb threatening ischemia secondary to severe multi-level peripheral arterial disease. Management required a combination of open surgical and endovascular technique, including bypass, grafting, endarterectomy, thrombectomy, and balloon angioplasty. After all the procedure intervention successfully restored the blood flow of the patient and improved the distal pulses and ultimately allowed limb preservation. Thank you. And our next presenter would be Steve.
Yes, question we need to understand, once you do the CT angiogram, most CT angiogram will show the flow. However, if somebody presents with diabetes and severe peripheral arterial disease, sometimes you have calcifications in the distal arteries, the tibials, that you really cannot really see well in the CT angiogram. It might look like you're seeing blood flow, but that vessel may be completely occluded. So it's very important that at the time of surgery, we're doing an unstable arteriogram to make sure that those vessels are really, they're not. If you affect treatment, you just walk away, they will come back with a complication down the road. Again, one of the presentations clinician was just presented is the fact that the tibial arteries can be entered into the vascular. Nowadays, we have techniques where we can use an ultrasound to isolate the posterior tibial artery as well as anterior tibial artery directly, posterior speech directly, cannulate them and do an entire endovascular procedure from that level. The advantage of that is you don't have to go to the groin. You got the patients within 30 minutes of the operative intervention, and it's a pretty neat technique that's coming down the pike. And additionally, another thing that we do, and since we present case in Bethany, that I experienced in Bethany, is patients have a lot of disease, young and old, and we have moved away from putting stents in the femoral uphill segment. We'll only use stents as a bailout procedure because our patients have extreme calcification. And if you put a stent in the femoral area, you're deemed to come back to that patient within a 6-month period. Our next presenter, Steve.
Hello. So the next case will be retrograde approach and high-grade stenosis. So we have a 72-year-old female here in the Beckley Appalachian region, and she presents with bilateral pain in both of her legs, and her pulses are absent, so her distal pulses can't be palpated. Her CT angiogram shows complete occlusion on the right, and she also has high-grade stenosis on the left of 80 to 90%. So she was taken to surgery, and the method used in this intervention was the retrograde approach. And the retrograde approach was used to cross the lesion in the femoral popliteal segment, and she was treated then with intravascular lithotripsy, a shockwave balloon. So we can see the procedure here. You see the arteries, you see the fempop region of stenosis and occlusion. And then here we have more images of the procedure. We can see the balloon is going in. And this is post-treatment. You see restoration of flow. So the patient was treated and the stenosis was less than 5% after the intervention, after the surgery. And she was discharged the same day in like 2 hours. And it was a successful procedure. So thank you very much.
You know, retrograde technique works very well. It cannot come from the top, it come from the bottom. And patients, the current use of intravascular lithotripsy in our patient does work well. And that's the ultrasound guided balloon inflation that fractures the plaque and remodels the plaque. Many years ago, before this technology became available, we ended up doing femoral bypasses. But nowadays, when patients even had bypasses in the past, femoral bypasses show up, occluded or thrombosed. If we're able to cross the native artery now with the wire balloon, we can affect treatment with intravascular and avoid redoing bypass. So again, it's easier for the patient. Thank you, Steve.
Thank you. Now to Dr. Anjali.
An early title of doctor. I appreciate it, Steve. Okay, so I'm gonna switch hats real quick from moderator to presenter. All right. Okay. So this is a 68-year-old male with severe peripheral arterial disease who presented with right leg pain and chronic non-healing lower extremity wounds. So further workup revealed significant right iliac artery stenosis and complete occlusion of the right superficial femoral artery. So because of the worsening symptoms and poor limb perfusion, he underwent an aortobifemoral arteriogram with right common and external iliac angioplasty. All right, so his medical history is essentially a perfect storm for peripheral artery disease. He has hypertension, hyperlipidemia, diabetes, COPD, coronary artery disease with a prior PCI, and known PAD, like I said, with bilateral non-healing wounds. So not surprisingly, his surgical history also reflects a very long-standing history of vascular disease. So surgical history includes PCI with LAD stenting, like I mentioned, a prior left femoral endarterectomy, multiple skin graft procedures, and a great toe amputation. These findings, they further support the severity and the chronic nature of the peripheral vascular disease. And his social history provides additional context for how his disease progressed. So this patient has a history of smoking and alcohol abuse. Honestly, we can make a game of how many times we've said the word smoking today. So if there's one thing we take away from today's presentation is that smoking is the biggest contributor to the progression of his peripheral artery disease. Okay, so this is his pre-op CTA, and preoperative CT angiography demonstrates two major findings. First, there was approximately 70 to 80% stenosis of the right common iliac artery and 60 to 70% stenosis of the right external iliac artery. Secondly, there was a complete occlusion of the right superficial femoral artery. And together, these lesions significantly reduced arterial inflow to the right lower extremity and basically explains his symptoms of pain and poor wound healing. So given these findings, the decision was made to proceed with endovascular intervention. This further just demonstrates what I was just saying. So surgical intervention, the abscess was access, not abscess. Access was obtained through the left common femoral artery and an aortobifemoral arteriogram was performed. And the angiography confirmed severe stenosis of the right common and external iliac arteries, as well as complete occlusion of the right superficial femoral artery. An initial attempt was made to cross the SFA occlusion through an anterograde approach. However, the wire could not advance beyond the lesion. So a second attempt was made, then performed through retrograde posterior tibial artery access, but the chronic occlusion could not be crossed from that direction either. So given these findings, the decision was made to then proceed with balloon angioplasty of the right common and external iliac arteries using a 6x40 and an 8x40 millimeter balloons. So post-angioplasty, the residual stenosis was reduced to less than 5% with excellent vessel expansion. So although the SFA occlusion remained untreated, the inflow through the iliac system was significantly improved. So the outcome, the patient tolerated the procedure without complications. Postoperatively, he had improved arterial perfusion with palpable dorsalis, pedis, and posterior tibial pulses. And overall, the intervention improved inflow through the iliac system and improved lower extremity perfusion. So although the SFA occlusion could not be crossed, treatment of the inflow disease significantly improved perfusion, and it may serve as a bridge to future intervention, including proximal SFA endarterectomy or femoral popliteal bypass. And that was my presentation. Right. And
That's correct.
Mhm.
Again, once you don't have to do everything at the same time. By improving inflow, patient has outflow, even though the fem pop segment was bad. The outflow that is, we can potentially do a FEMPA bypass down the road if we were more symptomatic. So it's the initial symptoms that Rural Hospital got better almost immediately. So we'll after that, it will against the smoker. You don't want to do a FEMPA bypass because you know he's going to smoke, and FEMPA bypass will occlude and it'll have tremendous amount of pain or end up in amputation. So that's a nice way to kind of think about it. The patient's immediate problem, leave him alone. It's good, but it'll go slow. And then down the road, if it gets worse, you deal with it. Thank you.
Okay, thank you. And we have Dr. Shaheen Kaplan to present. Thanks so much.
Good morning, everyone. It's such a pleasure to be here today, and especially to present with my wonderful colleagues. I'm going to be presenting an interesting case to you today. It's a surgical case on endarterectomy. So we have a patient who is 76 years old, and he's a heavy smoker. He was previously counseled regarding smoking cessation, but was not successful. Currently, he presents with peripheral artery disease, as well as increased discomfort and pain in his left leg with difficulty ambulating. In terms of his past medical history, he has COPD with exacerbation, he has coronary artery disease, and his right popliteal artery and iliac artery were actually previously stented. He also has first-degree AV block and sinus bradycardia. This was his preoperative CT angiogram, and if you see on your left-hand side, there's diffuse artery disease, peripheral artery disease, involving both the femoral and the popliteal segments. You can see irregular vessel contours and areas of narrowing and stenosis. You can see some bubbles as well that looks like calcification potentially. So the first thing we did was attempted a right to left CFA access, and you can see a progression of the images. On the far right, the image that has a circle was where we attempted right to left access, but there was barriers to get through, so we weren't able to get through. This fluoroscopy picture on your left that's circled depicts the plaque that was there that was not allowing the wire to cross. And you can see how large the plaque actually is. It's even larger than the artery itself. So it's a complete occlusion, complete total occlusion of that artery. So because we couldn't get through, we had to switch to a different surgical technique, so the hybrid surgical technique. And what was done then was, this is an overview of the surgical technique. So an incision was made, the artery was exposed, heparin was introduced, and then the arteriotomy was done. And you can see that the plaque was then removed. It was a pretty large size plaque. And then a patch was put onto the artery once the plaque was removed. There was calcium chloride as well as sodium bicarbonate introduced with the patient, and that was to ensure that there was no reperfusion. We did a Doppler check before there was closure, final closure, and there was strong pulses. And these are some pictures from the surgery itself. So on the left, you can see the arterial plaque. You can see a pretty substantial amount of plaque in that artery. Once the plaque was removed, you can see the specimen in the middle. And then on the far right, you can see the graft, the arterial graft that was placed. I believe it was a 13-centimeter graft. So in summary, before it was sutured, vancomycin powder as well as wound matrix was introduced, and that was to minimize risk of lymphocele. In the inguinal area, lymphocele risk can be quite high, so vancomycin and wound matrix would have helped that. Postoperatively, we also looked at DP and TP, and there were very strong pulses. And in this particular patient, then arterial flow was restored as well as the limb was salvaged. So, thank you so much.
It's important that we make intraoperative decisions based on where we are at the time of surgery. There's questions that's on the table. has had general anesthesia already. We will plan is to do an endovascular prevention and the wires don't go through. No matter how much we try, bring wires catheters to kind of advance the wire. You just met a solid hard plaque. That's, so there's just no way you can go from above to below. It just doesn't work at that point, and you have to quickly change your mindset. This is a case for indirectly. So just go in and get it done, and then that goes sample performed. And again, it's extensive, and the plaque looked like a little focal popcorn type plaque was extensive, a long area, almost 13 cm. So that's very impressive. Again, one of the concept is once you do that indirectly, you may be able to avoid the bypass. And this was the case where we did indirectly and avoided the bypass being done. So that's a nice way to restore flow. Thank you.
Hey. Good morning, everyone. I'm so happy to be here. So I'm Laurentia Gladji, and I'm a med student under Dr. Oye, and my presentation is on delayed embolectomy followed by compartment syndrome. So I'll give a background of this case before I start off. The clinical context is really surrounding acute limb ischemia, and oftentimes embolism accounts for the most part, which is about 30% of cases. And afibrillation is also a source and up to about 70%. There is a 30-day mortality of 9 to 15%, and amputation risk is 10 to 30%. Now, there's something really distinct about diagnostic delay, which had really complicated my particular case. And ischemia often greater than 6 hours significantly worsens the outcomes we find in patients. Delays increase reperfusion injury, increases the risk of rhabdomyolysis and renal failure. And early revascularization is a key determinant of salvaging the limb involved. Now, over to compartment syndrome itself, this is a complication that could occur with reperfusion itself, which is the intervention we do in cases of acute limb ischemia. So you find that there is an increase in the pressure surrounding the muscle compartment, and the rise in pressure causes reduced flow in the venous system and also impinges on the nerves as well. And compartment syndrome complicates embolectomy in about 6 to 20%, and it rises to 25 to 40% with more time gap between the ischemia itself and the intervention happening. And oftentimes the fasciotomy is what you would do in a case of compartment syndrome. So over to the next slide, which is the case presentation itself. The chief complaint of this patient was having leg pain for over 1 week, and keep the 1 week in mind because that would really progress as we talk about this case. And this was a 69-year-old Caucasian male with extensive PAD, peripheral artery disease. He had presented with left leg pain, and he apparently showed up about a week after, and even more days after this event has started. His past medical history included ischemic cardiomyopathy, coronary artery disease with a history of percutaneous intervention and coronary artery bypass graft. He had chronic systolic and diastolic congestive heart failure. And because he was a smoker, he had chronic hypoxemic resp failure as well. So surgical history, the CABG, femoral bypass, and PCI with a thrombectomy of the left lower extremity, which was a FEMPOP that was done in the past. Family history was a brother with coronary artery disease, and social history was quitting smoking. So he'd previously been a smoker, but quit smoking 1 month ago before this case had happened. He denied alcohol use and any use of illicit drugs. So the clinical timeline with this case was 1 week after he started having symptoms. He was in the ED, that's the emergency department, by like Monday, 6:55 p.m. He had all the complaints of a typical ischemia. He had leg pain, pulselessness, poikilothermia, so his feet was feeling cold. He also had claudication pain. So on presentation at the emergency department, a CTA with runoff was done, started on typical protocols to really intervene in the moment. He was put on admission that same evening and scheduled for intervention the following day, which was a Tuesday. And on Wednesday morning, we had done the embolectomy itself. So it was a left popliteotibial endarterectomy and arteriogram of the left lower extremity. And on Wednesday morning, it was found while under admission that he was having a hematoma in that surgical site. So he was scheduled that same day for another intervention at the OR, where we had eventually done a fasciotomy that same Wednesday evening. So the surgical management itself that had gone on was this patient had come in after 1 week of leg pain. Imaging confirmed that the arterial was occluded. We attempted balloon angioplasty first, but the artery was completely blocked. So we made a cut at the ankle and passed the Fogarty catheter through and pulled that clot out. And that was actually the part where we got the embolism that he had had on that left occlusion out. And this was really the defining procedure for this case because the pulse came back, the wound was closed, and patient was admitted overnight. Now, the following morning, a hematoma was found at the surgical site. He had pulselessness all over again, he had pain, the limb was cold to touch, so he was back in the OR that same day. We opened behind the knee, removed the old stent, and if you would recall in the past surgical history, he had a thrombectomy on the left leg. So we actually had to scrape out plaques from the four arteries, the common femoral, the profunda femoris, the superficial femoral, and the popliteal artery, and a Gore-Tex bypass restored flow, which was confirmed on X-ray. So intraoperatively, we realized that this patient had developed a compartment syndrome because you would see that there was a huge amount of blood really clotting in the area where his muscles surrounding this occlusion were. So we did a 4-compartment fasciotomy, and the leg was saved. There was no amputation done, and pulse was confirmed. And yet the patient was sent off for ICU management. Now over to the pictures. These are the plaques that we had taken out. And also you would see the stent actually that we also had to take out of this patient's left leg. And the outcome itself was the peroneal artery, which was occluded, flow was restored. The anterior tibial artery became patent. Unfortunately, the posterior tibial artery itself was still occluded even after this case. However, technically, this patient has his leg saved under 2 out of 3 tibial vessels, and that was enough flow to really keep the limb alive. So we did acknowledge at the end of this case that there was a possibility of another reintervention or even amputation in the future. And we've heard a lot about acute limb ischemia, so I would really cut that part short. However, this is an image that really shows how compartment syndrome looks, and you see the swelling around these muscles, which would press on the nerves and the blood vessels surrounding it, and you would see all those symptoms that I had highlighted. Now, the reported incidence of compartment syndrome itself, that's about 10 to 25% of acute limb ischemia patients. And the risk is highest in patients with a prolonged ischemia, such as this case. And large muscle mass involvement is also another risk factor. And extensive thromboembolic occlusion is another risk factor. And similar to reported cases, our patient had developed compartment syndrome after a delayed reperfusion of an ischemic limb. Now, the diagnostic pitfalls I really want to highlight is that restoration of pulses does not exclude compartment syndrome. Postoperative reperfusion pain can mask evolving compartment syndrome. So that's something to really highlight. And then pain out of proportion, tense compartments, neurologic deficits by the impinged nerves, and escalating analgesic requirements should raise a concern of a possible compartment syndrome developing in a patient. And delayed diagnosis is associated with increased risk of the patient losing their limb. And in conclusion, this case is one that highlights that a successful embolectomy or endarterectomy does not end the threat to the limb. So in patients undergoing delayed revascularization, there should always be a threshold, a low threshold for possible fasciotomy, hematoma developing, other complications you would typically see. And these are often essential to prevent irreversible ischemic injury and amputation. So thank you so much. These are the references.
Nice stuff, Lola. A key question for your board exams would be, you may ask what the compartment pressure should be for your effect fasciotomy. The answer is greater than 30. So don't forget that before.
Okay, hello, good morning. My name is Farah Gaston. I am a fourth year med student working under Dr. Oye. So today my presentation is on surgical management of acute on chronic peripheral arterial disease. And with this presentation, I am going to be comparing two cases of acute on chronic peripheral arterial disease requiring urgent revascularization. Through these cases, we'll review the pathophysiology of PAD, examine two different surgical approaches, and discuss why different interventions were selected based on the anatomy and prior vascular history. Okay, so the objective of this presentation is to briefly review the pathophysiology of PAD, present the two cases of the vascular surgery cases of revascularization, and compare the strategies used for these cases, and discuss factors that influence the vascular surgical decision-making. So why PAD matters? So as we've been discussing, throughout this entire morning, PAD affects a large portion of the world. It's not just simply the US, but in the US, it affects over 8 million adults in the US. It's associated with significantly increased risk of myocardial infarction, stroke, and cardiovascular disease. Major cause of claudication, functional impairment, and reduced quality of life. Can progress to chronic limb threatening ischemia, which of course we've been talking about again today, tissue loss, and amputation if not dealt with early. Early diagnosis and revascularization can improve the patient's limb and spare the patient from having to amputate. So the comparison of these two cases. So for these two patients, they did both present with acute right limb ischemia. The only difference was the first patient had native iliac to popliteal artery occlusion, whereas the second patient had a bypass graft that was then thrombosed, probably due to, not modifying his lifestyle changes, as Dr. Oye was previously discussing, if he's a chronic smoker, et cetera, having a bypass would be unfortunately thrombosed in this patient just because he did not, modify his lifestyle. Underlying diseases for patient one were severe multi-level peripheral artery disease, whereas for patient two, as I stated, they have prior bypass and severe PAD. The surgical or intervention approach was a hybrid revascularization for patient one, and for patient two was a surgical embolectomy. The procedures done was an embolectomy, stent, and angioplasty plus lithotripsy for patient one, and then for patient two was the Fogarty catheter, lumpectomy of the bypass graft, which we'll show pictures and such later. And the goal was just to restore, for patient 1, restore the native vessel flow, and for patient 2, salvage any of the existing bypass graft. And of course, for the outcome, so that they could have restoration of blood flow in both of their ischemic limb. Okay, so why different procedures? So as mentioned before, patient 1 had a native artery occlusion, whereas patient 2 had a bypass graft occlusion. So, and then the remaining endovascular. So patient number 1 had an endovascular / open approach, where patient 2 just had an open surgical approach. Patient 1 had stent and angioplasty was required, and whereas patient 2, clot extraction was required, which we'll see later on. And then patient 1, native vessel reconstruction, and patient 2, graft salvage. So disease progression for PAD, if PAD exists along a spectrum, early disease may be asymptomatic, as we could see here with the disease progression, or cause mild claudication, as my fellow colleague was speaking on prior to this. Advanced disease can result in pain, tissue loss, non-healing wounds, and critical limb ischemia. So for patient number 1, this patient was a 69-year-old male who had history of severe peripheral artery disease. He had previously a right iliac artery stenting. His chief complaint was right lower extremity pain and concerns for acute limb ischemia. Physical exam revealed a cold right foot and diminished distal pulses, evidence of impaired perfusion. And clinical concern was threatened limb ischemia requiring an urgent vascular evaluation. So this is the CTA of patient 1. So on this CTA, we see a lot of, stuff going on where you see the stenotic vessels. So you see occlusion of the right common iliac artery and occlusion of the right external iliac artery, occluded prior iliac stents, and a stated multi-level femoral popliteal disease. So as you see within the CTA, you can see the big pieces of thrombose, or like the clots of the right common iliac artery and the external iliac artery. So you see a lot of things going on within the CTA. And so what was done for this patient? So as stated, they had an embolectomy, a state placement in a shock wave lithotripsy, and drug coated balloon angioplasty. So that was for patient number 1. So we ended up doing a hybrid revascularization with embolectomy, stenting, shockwave lithotripsy, and drug-coated balloon angioplasty. So post the outcome for this patient, so pre-intervention, as you could see on the right-hand side or the far left, pre-intervention, severe narrowing / occlusion before treatment and poor distal runoff. And then post-intervention, you see the reestablished arterial patency. So you're able to see the runoff in the post-intervention. You're able to see the complete blood flow actually be reestablished. Improve contrast flow through the treated vessel and better distal perfusion. That was the outcome. And this was pictures we taken during the surgery and post, removing all of those plaques that you were able to see in the CTA picture prior. And as you can see, there were many. So now for patient number 2, this patient, he's a 59-year-old male. He had history of severe peripheral vascular disease, claudication, dyslipidemia, atrial fibrillation, systolic congestive heart failure, ejection fraction of 44%, bilateral lower extremity thrombophlebitis, sorry guys, additional chronic disease. So he had an extensive smoking history as well. So as mentioned, someone with an extensive smoking history receiving a bypass would not be beneficial for this patient, but he did have a prior femoral popliteal bypass graft, which eventually did get occluded. So his chief complaint was right lower extremity pain, concerns for acute limb ischemia. So on physical exam, we saw diminished distal perfusion, evidence of acute vascular compromise, and threatened lower extremity ischemia. And of course, our clinical concern would be acute thrombosis of existing bypass grafting resulting in limb-threatening ischemia. So this is his CTA. And again, you're able to appreciate the thrombosis of the bypass. So occluded femoral popliteal bypass graft, as you can see on the CTA, and bilateral superficial femoral artery occlusions, and popliteal artery occlusion and extensive collateral vessel formation. And what was the intervention? So for this patient, as mentioned before, we had to do the procedure of Fogarty catheter thrombectomy. So that is the removal of the thrombus by the that was found within the bypass graft. Intraoperative angiography to evaluate the patency and the runoff of the now restored blood vessel, and graft salvage procedure, restore flow through existing bypass. So the outcome, as stated, was restoration of blood flow, improved distal perfusion, successful graft salvage, and limb preservation achieved. And this is a angiographic progression of the patient's, so prior to the procedure for the far left, you can see that it had initially a graft occlusion, so you weren't able to see the full blood flow. But then during the procedure, we saw restoration of contrast flow flowing through the thrombectomy. And then the bottom right picture shows the improved graft patency and distal runoff. So the outcome for this procedure, so pre-intervention before thrombectomy occluded graft with poor flow, and now post-intervention was a reestablished graft patency, improved runoff to distal vessels, successful limb reperfusion, and preservation of existing bypass conduit. And this is the picture taken during the procedure, and as you could see on the right-hand side, that is the piece of the thrombus that was found within the bypass graft. So the take home for this case is peripheral artery disease is a progressive manifestation of systemic atherosclerosis. Acute limb ischemia requires urgent and diagnosis and revascularization to prevent limb loss. Treatment strategies depend on the vascular anatomy, disease severity, and prior interventions. Hybrid and open surgical techniques remain important tools for limb salvage. Successful outcomes rely on restoring perfusion while preserving future revascularization options. For both patients required urgent revascularizations, but anatomy and prior intervention dictated different surgical strategies. So successful limb salvage depend on restoration of perfusion. And that was the end of my case. Yes, and my next, I'll be introducing my colleague, Alfred. Thank you.
Hi, everyone. I'm Alfred. I'll be presenting a case about symptom-directed revascularization in bilateral lower extremity PAD. So, history of present illness. It's an 82-year-old male transferred from an outside hospital. He had multiple risk factors, including smoking, which is a common theme, but also hypertension, peripheral vascular disease, diabetes, CAD with prior CABG stent. He presented with worsening left leg pain over the past 4 days, and also difficulty walking, denied any focal neurologic deficits. And I guess of note, we were discussing 2 cases ago, importance of considering acute limb ischemia, but based on these symptoms, limb was warm, pulse was noted, so unlikely to be like an acute limb ischemia. Also no signs of paresthesias, paralysis, or oculothermia. But otherwise, he had the tenderness and presented with pain. He had vascular workup. This was done in an outside hospital. Specifically, he had ABI and CTA showing bilateral PAD. On the right side, he had severe peripheral vascular disease by the ABI, and also showed popliteal occlusion with intact collateral flow, and also 90% or so stenosis. On the left side, it was only mild to moderate PVD, as shown by the ABI, and there's greater than 70% left to distal femoral stenosis. So key point, the imaging looked worse on the right, despite the symptoms being worse on the left. So regarding the operation, the procedure, so it started with a bilateral runoff angiography via the right femoral axis. And through that angiography, bilateral PAD was confirmed, and the worst presentation on the right was also confirmed. On the left, that was where we ultimately performed the femoropopliteal and common iliac angioplasty, which was symptomatic. And after the procedure, immediate outcome, the pain was resolved. So regarding the procedure itself, here are some images we see on the left. On the left, it shows 90% femoropopliteal stenosis, and confirming that this was a severe but treatable lesion, with also some stenosis going more distally too. On the right, as we see a patent 3-vessel runoff. This is all distal, so that 3-vessel bundle there. And as Dr. Oya emphasized, the importance of intraoperatively assessing during case 3. So based off of the patency, we know we can. It's more likely that the patient will have a good outcome from this procedure. Here's the ballooning being done from left to right. And also same idea, but done more proximally, so that entire segment needed to be ballooned. And after the ballooning, there's only less than 5% residual stenosis, so pretty good flow now. Also seen, it was confirmed that the that the left iliac artery had stenosis, and it was able to quantify exactly how much, 70%. So we ballooned that too. And like before, we got it down to less than 5% residual stenosis. So I guess in summary, to some of the big teaching takeaways of this case of acute worsening of a chronic PAD, it's important to recognize symptomatic PAD through the signs of claudication, rest pain, wounds, etc. And to do an appropriate imaging workup if stable, like an ABI, to treat systemic risk, including smoking cessation and medications, and to vascularize selectively, so prioritizing disabling symptoms or limb threat. And as Dr. Oya mentioned during case 2, we want to, the symptoms are what identify which limb to treat. And the imaging kind of gives us an idea of the anatomy, which will subsequently guide the intervention. And I guess this is kind of the central point. So the patient had bilateral PAD, but and I guess during intraoperative, I guess the left side was where the symptoms were, despite the right side having worse anatomic disease. In fact, even during the procedure itself, during the intraoperative angiography, it was found that 100% of occlusion was found on the right side. Yet, despite all that, we still treat based symptomatically the left leg. And takeaway, don't just treat the worst side, go based off the symptoms. And some references.
Very good. Thanks.
And then, thank you. Thank you.
That's keyword. Listen to patients, history physical. They'll tell you what's going on and treat the symptomatic event. Don't treat the CT angiogram, treat the patient.
Great.
Thank you so much.
First. And just a quick conclusion of, I guess, all of the slides. In general, PAD is not just a local, but also a global disease burden. And revascularization and timely intraoperative decision-making helped to restore blood flow and supported limb salvage across all these cases that we've discussed today. And finally, improving PAD outcomes requires addressing risk factors, and as Dr. Vereen emphasized, the social barriers, including substance use and addiction, that affect access to care and long-term health outcomes. And now I'll turn the floor back over to Angie.
All right. So that concludes today's Grand Round presentation, and we really appreciate all of your time, your participation, and your continued support of medical education. I know the slide says questions, but don't direct any of those at me. So I would like to welcome Dr. Oye back to the floor to close us out, and if anyone has any questions or discussions to ask Dr. Oye. Okay.
Any questions so far? Any lingering concerns about the presentations so far?
Yeah, I'm really impressed with the students. They're giving very good scientific presentation. I think they're they ball well for the future. But 2 questions. The compartment syndrome, you did say the critical pressure is 30. Did you have to recommend just going on clinical presentation rather than insisting on the pressure? I mean, on this case that presented, did you do any pressure measurement? Do we even have that?
You can do a pressure measurement. In this case, it was very clinical. At that time of surgery, you could actually see the muscle tenseness. So there's no doubt. And as soon as you make the incision, the muscle bulges out. But if you are concerned and want to check your pressure, you can just stick a needle in and check your pressure. It's usually 30 or greater. Yeah.
So basically what it's saying is that the clinical percentage is 100.
Correct. Yeah, you can tell from the tenseness of the lower extremity. But for the boards, they have to know it's 30 or greater. Yeah. Any more questions? Again, it's important. Thank you very much for the opportunity to attend this program today. As a way, I am passionate about ensuring that the future of medicine is handed over to young folks like you, who would continue to make inroads. Thank you for all the wonderful presentations. You have done a great job, as Dr. Shangade indicated. PAD, and also have to thank Dr. Vereen for his insightful drug addiction talk, which, as you well can see, some of our patients have PAD. Once they have PAD, some of them want to keep smoking, don't want to do their what it takes to do well, and actually go out and get illicit drugs to keep the pain under control, and sometimes get addicted to that. So it's a all-encompassing milieu. In our climb, patients smoke a lot. One of our presenters, Ms. Tamara, Dr. Tamara mentioned in the Niger Delta, the pollution, petrochemical pollution, is of great concern. What happens is the multinational companies come into the Niger Delta, part of Nigeria, was quite rich with oil exploration and oil theft. The waters are polluted from contamination, and people drink water, eat out of the water, and take showers out of water. And we don't smoke as much as the Niger Delta, but have as much disease in terms of severe disease like we present in Beckley. So there has to be some correlation somehow between petrochemical contamination, Niger Delta, and smoking in the United States that may be making this high. We also do know the risk factors of PAD include genetics, which it's there, and the modifiable risk factors such as diabetes and hypertension uncontrolled. So it's a great problem worldwide. It's a challenge. Over 237 million people affected by PAD worldwide. In the United States alone, greater than 12 million. In the Niger Delta, we know it's about the same. The population of Nigeria on paper is about 232 million, but I think it's more like 300 million because a lot of people walk around Lagos that are not counted in the census. We know that. So again, once we look at the disease profile in PAD, and Beckley is unique because it's a rural community, but we have the added advantage that we have technology to provide care. When you go across the world where the technology is not available, the only options that your best friend in those climate would be an orthopedic surgeon. They just cut your leg off, and that's it. It's one and done. Again, that comes with the added cost of depression and death that can occur. So it's important that we continue to stay aware about PAD, not only know about PAD, but tell your friends, your family members, and to be able to identify when PAD is the diagnosis, because making the wrong diagnosis can be limb threatening, can cause limb loss, and maybe a lawyer after you, or lawyer or two after you. So it's important as part of your training process that you understand when you see patients with leg pain, arm pain, you have to identify if it's an arterial disease, a venous disease, a neurological disease, a muscular disease, or orthopedic problem. And the process can be very easily done. If they have pulses, they're less like a PAD. If they don't have pulses, it's more likely something else. So don't fall victim to saying somebody does not have PAD when indeed PAD is the main problem, and you might be treating person for arthritis. Yes, you can have arthritis and PAD at the same time. So it's very important to know that. Again, we'll continue to move on. Our next scheduled the ground round would be in September, and the yearly Endovascular Conference for Africa and Rural America is scheduled for October. I believe sometime between October 20 and October 30. We'll figure out the exact date later. But we'll do one grand rounds before then in September. Then the 9th annual Endovascular Conference would be in Lagos and Bielsa and Beckley. So we'll have virtual talks from here, and I'll be on the ground in Lagos. And this time around, I believe we'll have some Dr. White supposed to be coming along this time. So we'll see how that goes. So again, thank you very much for the hard work you've put in getting this presentations together. I appreciate it. I like what you've all done. And again, continue to work hard, study hard, and residency will be in your future, and clinical practice also in the not too distant future. Thank you very much, Doc. Thank you, Dr. Vereen, and thank you again, Dr. Shangadan. All right, let's go. It's lunchtime. Let's go. Dr. Shangadan, we're going to go. What's that? We're going to hang out in breakfast. Hang out. Oh, wow. You guys know.